Thank you for your patience in this, and if anything, maybe what will resonate from this lecture is you might know somebody, or maybe yourself has had this really annoying back pain that you just can't seem to figure out. Well, maybe it's sacroiliac dysfunction. So without further ado, look at that. I barely pointed up and actually clicked over. So there's me. I'm originally from the East Coast, went to Virginia Tech. I did my PA school at Rosalind Franklin University. All my clinicals in Chicago. My first start in Chicago, that was more the general crazy orthopedic experience, doing some level 1 trauma. And then I moved to Indianapolis in 2019 to work for Indiana University and have been there ever since. So disclosures, I do some consulting work for SI Bone that makes an SI fusion product, and J&J MedTech, and we teach in the course tomorrow morning for advancing enclosure. Moving on. Anatomy biomechanics of the SI joint. You guys are probably pretty familiar with the anatomy of the pelvis. But I think the most important thing from this slide is noting that when you look at the distance between that sacral promontory and then those nice little sacral foramens on either side, and then here is your SI joint that runs right here, you can understand that anything involving that could also potentially aggravate some neurologic symptoms at the same time. So sometimes there can be crossover. This is a top-down view, so again, just kind of demonstrating that that little platform of that sacrum that separates the spine from the rest of the pelvis is pretty narrow, some small real estate. This is a great picture here in that, I don't know how people are familiar that SI joint is not just a vertical line, it's more kind of like a boomerang, or they call it kind of an auricular, almost like a gear structure. Also, again, it really comes into play when you're thinking about the way that it rotates, the way that it counters some of the shear force that comes down to the spine into the pelvis. Lots of ligaments. I don't know if anyone here saw the second Happy Gilmore movie by any chance. They talk about this separation of this ilio-lumbar ligament right here, and all of a sudden these golfers have 360 degrees of motion. I call BS, but it's for Hollywood. So in any event, so obviously there's a lot going on there. So things that can cause sacroiliac dysfunction are not just limited to the joint itself, but you think about a lot of disruption of some of those ligamentous structures, whether that comes from something that maybe was traumatic, is an overuse injury, or at the same time just thinking about the concept of pregnancy, right? We have any mothers in this room, right? Kids cause back pain, right? That's the moral of the story. Stretches out the ligaments, unfortunately do not always regain a lot of that tension, okay? So there's differences, obviously, in the morphology between men and women. With the women, it is going to be a wider set base, with the men more narrow, but it's longer from an anterior-posterior dimension, where it's the opposite for women. As we were talking about pregnancy, so obviously that shifts a lot of the mechanics of the spine, and therefore down in the lumbosacral, joining into the pelvic floor, increased extension, stretching the abdominal muscles. So obviously that there's a lot of muscular compensations that can develop from this too. So what we know about the SI joint, it's just like any other joint that you think about as far as a hip and knee, that there is synovial fluid, type 2 collagen, and hyaline cartilage. Nutation and counter nutation is basically implies that it's not a completely static joint. It does actually provide, so the nutation we think about would be a little bit of a tilt forward, and the counter nutation is the opposite direction, coming backwards. As it becomes relevant, and kind of the spoiler alert is I do a lot of spine surgery, and one of the surgeries we do quite a bit of is spinal fusion. You think about somebody having an extended sacrum, let's say the L5-S1 is fused, or even their L4-5 and their L5-S1 is fused. Well, now you got this big super sacrum that's sitting in between those two joints. One of the biggest things we tell our spine fusion patients is that there's a possibility we might be coming back here again for another surgery because of what's called adjacent segment disease. If you immobilize one joint that's next to another, the body is going to compensate by increasing the mobility at that other joint level. It's no different when you think about the sacroiliac joint. Okay, prevalence and burdens of disease. So I think this slide is not surprising, and the kind of humor here is, yes, my data is a little bit out of touch, 1995 and 2009. I would be willing to venture that those numbers have gone up quite a bit. Why does it hurt? Again, not always strictly from the joint itself, like a traditional hip arthritis or shoulder arthritis. It can be because of some functionally unstable loading. So again, not unstable in the sense of like a dislocated joint, but because of the stretch on the ligaments and the decreased muscle control from deconditioning or involvement of something else. That's what can kind of create as pain generator. So we're talking about maybe 30%, as high as 30%, or in some cases in the De Palma study here, that about up to 43%. Well, that's actually, sorry, in post-lumbar fusion, but 30% in chronic low back pain. So if you have a friend, family member, yourself, you've dealt with back pain for years and kind of written off as do the physical therapy, lose weight, and strengthen your core. Thinking about this factor of could this be sacroiliac dysfunction, there are very different ways in which a therapist can go about to treat that. And some of it is also kind of looking at the, in kind of more the kinesiology terms, think about, working on the hip and the pelvic floor as much as you think about strengthening the spinal erectors and the abdominal muscles. This is an interesting slide because it shows in here SI joint pain is kind of right here at the very beginning of this yellow box. It's right next to severe COPD in terms of limiting someone's life. Parkinson's disease is also in that area. Advanced congestive heart failure, right? Chronic depression. So this just goes to show you when I see somebody in the office, and I think that this isn't a surprise that somebody dealing with chronic low back pain, although it might not always be something that's glaringly surgical, it's really affecting this person's quality of life. I want to see, is there something I can do about this besides just write them off and send them to the pain specialist? Again, this harps really kind of on the changes that are going to happen biomechanically with the SI joints with any type of lumbar fusion. 75%, very high number. Now, I'm not just arbitrarily CT scan looking for something else if I'm ordering a CT scan of someone's lumbar spine. If they're coming in and they've had a previous lumbar fusion, that may be one of the studies that I'm thinking about if I don't see robust bone growth on standard x-rays. If there's anything that looks moderately lucid about the screws, we call it a halo effect. You'll see somebody who's had posterior spinal hardware with screws placed in the pedicles, and you'll see literally a shadow when you zoom in on it around the screw. It shows that screw is loosened over time. Doesn't always mean that that person has what's called a pseudoarthrosis, but obviously it needs to be ruled out. That CT scan of the lumbar spine is also going to give you a little sneak peek down into the SI joints because they are adjacent to the lumbar spine. Really just driving home the message, more levels you have used, the greater chance you're going to get SI dysfunction. More added emphasis. Okay, this kind of shows a little bit in the opposite that somebody who also has poor biomechanics with the hip. I'll give you kind of a reference point to say that I can think of a patient actually recently who I saw who had a previous L4 to S1 fusion. And the reason he came in to see me was not for sacroiliac dysfunction, but because he was having really significant anterior thigh pain. Automatically for me, that triggers the response to say, that sounds like an L3 dermatome, and what's above the L4 S1 fusion he has is L3-4 disc. Sure enough, on his x-rays, really significant adjacent segment disease. We had to treat that first. I mean, that was his main complaint coming in. We're not going to prophylactically treat this guy's SI joints. However, he also had bilateral hip replacements. So what do you think happened after we did that L3-4 fusion? Next problem comes up. Now it's like, I got this pain right here. And he's pointing right over that sacroiliac region. And we're going to tell you what that is here shortly. So three main categories that you kind of expect to see this in patients. And like I said, first one, obviously very relevant for me for the post-lumbar fusion patient. Trauma, falling on the affected side that maybe potentially could have disrupted one or multiple ligaments that we saw in one of those previous slides. And again, the postpartum, just from the changes to the pelvis through the pregnancy. More or less also the delivery and then being on the floor all the time with the kid. So this is alluding to that as we're kind of looking at some of the diagnostic challenges and this patient's coming to your office, first thing we're thinking about is, we want to, what kind of imaging do we think is going to be the most appropriate? I I kind of singled out here that obviously in the x-rays, making sure that if you're getting an x-ray of somebody's lumbar spine, I always tell my technicians, if they're coming for low back pain, I don't necessarily care what's going on in the thoracic cavity. Maybe for the general surgery people, that's more relevant. I just want to see what's going on down here. So I have the technician really focused on getting more down to the pelvis so I can see a nice AP view of the hips. I'm looking at the sacroiliac joints. I'm also looking at the hips. I'm knocking out three very important anatomical considerations with one x-ray, so reducing the exposure overall. The Judet view is also, I think I would probably do that secondarily if the patient was seeing me in follow-up. They kind of failed or been ruled out of other pathology of the lumbar spine or the hips. I might do some dedicated Judet views, and also it's kind of an oblique angle that allows me to see a little bit more clearly into the SI joint. MRI would be better than a CT scan, but a CT scan is also relevant, and maybe potentially getting it for other reasons. I'm considering the age of the patient. So despite us being ortho bros and liking to do x-rays, we are cognizant about the radiation exposure with CT scans. So an MRI obviously can show edema patterns. If there's a joint diffusion, you can see that on MRI too, so that can be helpful. This is a nice slide because this shows us just how much of that overlap that the SI joint has with hip pathology and lumbar pathology, right? Doesn't look too different, does it? Right? Someone comes in complaining of a sciatica. If I do an MRI of their lumbar spine and there's no compression on any nerve roots whatsoever, I can think more along the lines of maybe this is a sacroiliac problem instead. There are also issues sometimes with patients having groin pain, not an inguinal hernia. It's not some kind of internal derangement of the hip, but it could be because, again, sacroiliac joints, think of this as all part of that pelvic ring, right? So my trauma PAs, right? You got to work close in hand with the ortho bros, right? So if somebody has an open pelvis, right, big problem. Usually there's other things that you're probably working on as well. So you're probably seeing a lot of that hand in hand. Those patients that they don't already have a big long sacroiliac bulk going through for some type of vertical shear or U-type sacral fracture or spinal pelvic fixation for that matter, those patients that's your traumatic sector of people that are probably going to be having issues down the road. So get them set up with physical therapy once they clear from you, and be thinking about your ortho friends who are going to be dealing with this person in their back pain for a long time. Okay. So, when did the pain start? Again, thinking about trauma, and even something as simple as a lifting and twisting mechanism, right? There's kind of that anterior load that typically gets associated with loading of the disc and disc herniations at the same time. Anything that kind of causes, or think of this like as you're taking stairs, anything that causes an extension extreme and a flexion extreme of one hip versus the other is really going to accentuate the nutation and counter-nutation forces we were talking about in that first slide, okay? So, like I said, they're not immune from having any type of extremity symptoms. So we can't, of course, we want to rule out any sort of lumbar nerve root impingement. There can very much be some overlap. So if it doesn't seem like it follows a classic dermatome where it's very vague, that's something I can certainly throw into the mix. If you have prior lumbar fusion, iliac bone graft harvest, which I don't think anyone's doing that anymore. Most of it's going to be cadaver bone graft. We're just going to be extracting autograft when we're doing a decompression by doing laminectomy. Recycle that bone from the bone graft. Pain going from sitting to standing, and also with the disturbed sleep patterns, they'll find that sleeping on one side is preferred. So they want to sleep on the contralateral side, the side that's having more of the pain and dysfunction. And same thing as I talked about doing stairs, bending over and twisting the bed, and then anytime also weight bearing on that side too can be more painful. Great picture. The patient comes in your office, she's sitting like this, then I know we got a winner that either she has a foraminal disc herniation in the lumbar spine, or it's probably something that's sacroiliac in that case. So favorite quote there is, I literally had pain in my butt. No one has ever said that to me specifically, but they might kind of point and say, yeah, it's a pain in the butt. So, important finger test. When you ask that person where that pain is, and they point to this area that is within 1 centimeter of the PSI is infromedial, right? She's pointing right over that sacroiliac sulcus. And that is something that is definitely like if they come in on a second time, let's say you sent them to some physical therapy, didn't get any better, where do you still hurt? they point right to that same spot. Not this hurts, where it's kind of like all generalized and all over the place, but they'll be very specific about it. Not every single person is going to have it. That doesn't mean that if they don't point to that exact area, then you just brush it off and that's it. But typically that's something that's a good sign that that's probably what's causing it. So let's get into some of the other physical exam things. We'll get more specifically into the injections, but that's kind of your algorithm. So getting that history, the foreign finger, I put that in my physical exam more than anything, even though that is, they're subjectively showing you that's where the pain is. I'll obviously try to reproduce that by doing a palpation in that area. So again, keeping in mind all of our landmarks. I like this picture on the left here, even though obviously we know this anatomy very well. The difference between the ilium and the greater trochanter is where it just shows that you really need to keep your hands as far away from that greater trochanter to really get adequate provocative stress on the SI joint when you're trying to tease out what this is. A lot of patients can have some lateral hip pain and hip bursitis. If you go pressing the lateral hip, it's just going to irritate that. You're not going to get anything that's productive from diagnostic value of their SI joint. This hip physical exam slide, this is great. So this is where, I end up combining a lot of things in my exam, and not to make this something that just ends up being more burdensome, like, oh, I got to separate out a completely separate exam for this. When I'm doing some of these hip maneuvers, it goes in with my neurologic testing. It also goes in specifically and straight into some of the provocative testing for the sacroiliac joint. So I'd have the patient either sitting or lying down on the table, and part of that really just depends on frailty of the patient. If I don't feel comfortable getting them on the table, there's some things we can do that can modify that test. But when I go to straighten somebody's leg and put them into a knee extension, right? First thing I'm doing is a straight leg raise test, right? Do they have any pain? Does that irritate the pain that goes down the leg? That might be more specific towards disc pathology or lumbar pathology. Typically not so much an SI dysfunction. Once the hip is up in this level, I give a little resistance down. Can they resist against me? Great. I know that their L3 and their L4 are firing. I can also do a little dorsiflexion test to make sure that their ankle is firing too, okay? If they're not getting pain in the groin, I've knocked out what's called a Stinch field for internal derangement of the hip. And then from there, I go into a flexed position. I can bring it across the body, and I can bring it out. From right there, from that point, I just did the fader and the fair, piriformis, and bringing out and down into a favor. And that's also, you're scouring the hip at the same time. I knocked out all four of those tests in that one sweep. Now, you don't just go through and say, hey, did any points in time hurt you, right? You got to kind of take your time and stop and pause at each of those extremes. But that just kind of shows you right there how it can be very fluid with your exam. And while it is ideal to have the patient supine to get the best test, I have had patients have positive tests in a seated position. So don't think you have to be a WWF wrestler in terms of getting them on the table. So yes, you should have some tenderness over the sacral sulcus there. Tenderness of the pubic symphysis, I'm not as worried about that. Might be more relevant if the patient had pelvic trauma. Yes, with the punctum testing, the sit to stand, the stair step, right? Again, thinking about that idea of the affected side will be an extension. So when they step up on the opposite side, it's that transition. So if they take a really high step up, it'll end up causing that stress on the SI joint. So you have to have 3 out of 5 of these tests, which we're going to get into in a second. So they kind of rate and they say that the distraction and thigh thrust are and compression are more positive tests. I didn't show you those yet. I only showed you the favor. Okay. So we'll get into the other ones, and there is a nice little schematic on this side. So it shows you in doing these tests from the distraction, which is in the first box over here. Kind of right here. Distraction, that's your thigh thrust, favor, compression, and Gainsland. Obviously the most complex, right? Very hands-on in that case. And this one here in this first one, this is, think about anyone who's had an acute abdomen you've treated. This is, again, the general surgery reference. Guarding, if you put them into an extended position, they're almost like curled to a ball, right? When they're in a lot of pain. I'm not there. You guys are doing it, not me. Okay. But so usually people are not going to be very receptive to being completely extended on the table and knee pressing on the front of the pelvis. Get the knees relaxed a little bit. Put a little bolster underneath if you can, or just a pillow. Even just having the patient bend their knees a little bit is going to get them to relax some of that abdominal rigidity, so you can actually try this distraction test. Then the next thing that is key is the hands crossed over maneuver, because I'm actually trying to apply, and you can see little curly lines where you're showing the rotational forces. You're trying to almost like you're splaying open the pelvis. That's what is going to manipulate the stress as much. So clearly it's uncomfortable to press on the front of your ASIs if you did that right now sitting. It just doesn't feel good to dig your hands in there, okay? Somebody who's having sacroiliac pain doesn't care about that. They feel it all in their back. So you make sure that they differentiate, say, no, I felt that pain in my back when you did that, and start to apply that pressure. Women are typically going to be more flexible than guys, right? Goes back to the whole pregnancy, different morphology of the pelvis too at the same time. So I'm doing this on a male patient. I'm not expecting to get too much. I think it's better for women anecdotally. In the thigh thrust test, that is just a complete anterior posterior force. And then the compression test that's skipping ahead is a horizontal stress test. And then going to the Faber, that shows another way to promote some of that rotational stress. And then finally with the Gainsland, that's just if I feel like I'm just kind of striking out and this person is a little bit more mobile and capable. There is a modified way to do this in a seated position, but essentially, again, when I talked about with the stairs, the affected side is going to be the extended hip. So if someone is sitting down, I don't want to put them on the table. What I might have them do, if they can at least sit at the edge of the table, pull their good side thigh up towards their chest. I'm going to kind of hold on to their back and let them lean back. And all of a sudden, boom, here's your modified Gainsland. Oh, that pinches on the spot of my back. Okay. Positive Gainsland. When we proceed with an SI joint injection, it seems pretty obvious when they've done physical therapy, you've done all these physical exam findings that point to that. If you want to confirm the diagnosis, you have to do a sacroiliac injection. You can't recommend anything else beyond that unless the patient doesn't want to do anything with therapy, which is fine. This is not a life-threatening condition. This says that the NAS criteria is greater than 75% reduction in pain. The majority of insurances are going to want 80%. And I think 80% honestly is a better number because a lot of times if I'm asking a patient, how do you respond to the injection? I want to, typically I think a 1 out of 10 pain scale translates a lot easier than how much percentage relief did you get? Whether they get either 0% or 100%, right? So if they can at least tell me that they went in for the shot and it was 10 out of 10 pain, and they got reduced down to a 2 out of 10 after the shot, I was doing great. Well, what's the difference between 10 and 2? 80%, right? There's your 80% right there. So I think you can use that to extrapolate a little bit better in terms of the criteria points to say this was a positive injection. The first time is going to be with an anesthetic only between 2 and 2.5 cc's, also with a contrast. So it has to be done under fluoroscopy to really count. Then the second time, you can do it with an anti-inflammatory. Now, why would you not want to do an anti-inflammatory the first time around? Potential systemic benefit of the corticosteroid, right? It might be masking what's actually caused the problem. Not to mention, go back to the previous slides and looking at the anatomy. If somebody also has some lower lumbar degeneration, they've got a degenerative disc at L5S1. How do I know that there isn't some rent in that SI joint? Now, you're seeing the contrast going through, but there could still be some systemic absorption in that area from local blood flow, capillaries, whatever. It's happened, right? And then you repeat that same person, or have them get another injection, happens to be anesthetic only, not nearly as effective as the steroid. It does happen. This shows kind of the location of it. So they're trying to go from an inferior approach, and you can see in the kind of bottom left picture here, there's that contrast dye that's diffusing up through the joint. And then afterwards, if the patient's moving a lot better, and the key is you got to catch them within the 5 minutes afterwards, because that might be as long as that anesthetic lasts. If they're lucky, they might get a day. I had a patient recently that she called me, she was almost in tears. So the first time I could walk my dog in a year. This lady's been through a double anterior lumbar and body fusion. I thought she had SI dysfunction my first heart attack. And then she started developing these very strange recurrent radicular symptoms on the opposite side. It was on the right side before, and it was on the left. And we got a new MRI for her. She had some residual neurofrangial compression. We decided to say, let's go ahead and make sure we do a decompression first and get rid of what we think is causing a lot of this radiant leg pain. She had a positive epidural at the same time. So immediately, I'm not even thinking SI dysfunction. Did that, did a little bit better for a while, pain came back. Still always had this nagging pain in that forearm finger dang area. And this is a lady also that has history of Pretty bad anxiety, depression. She sees a therapist. A lot of people have written her off, right? So now we're kind of starting to get some traction where she's had these positive injections. We're now considering the idea of sacroiliac fusion for her. Now, fortunately, because she had standalone implants from the anterior approach lumbar surgery, which, again, apologies, I should have brought those slides up. That's an ability to basically fuse the spine through the disc only without putting in any posterior hardware. If there's posterior hardware that's present, that can sometimes make the surgical approach to the sacroiliac joint a little bit more challenging. Because if there is a S1 pedicle screw that might be sitting right in one of the areas where one of those top screws from your plan of fixation is for the sacroiliac joint. So we'll see more of those here in a second. Okay, so the injection protocol, as I said, you want a contrast meeting for it. You need to document, what the percentage relief is. And again, I want to get on the phone with them within the first day. Because if you wait till 2 weeks, now it didn't work. Because their expectations were not met, it didn't work. Positive diagnosis is greater than 8% relief within 5 minutes of that injection, roughly, give or take. So non-surgical options, pain medication, we're just gonna get rid of that one. I mean, anti-inflammatories, right? Topicals, those are gonna be obviously better. The external support's a good one, and I can hone this one down a little bit more. So going back to some of the provocative tests, talking about the compression, that's that horizontal, that medial to lateral compression force. When somebody goes into a back support or a back brace low over the hips like that, it may actually provide relief. But that seems kind of counterintuitive to doing a compression test. You're absolutely right. And this goes back to the original point that sometimes it's not always the joint itself. It might actually also be ligamentous involvement. So if there's laxity or dysfunctional instability, that patient's gonna respond very well just from trying on a back brace. I literally tell them, go on Amazon and buy yourself a sacroiliac belt and see how that makes you feel. I had a lady that was 84, osteoporosis, thankfully being treated, degenerative scoliosis, leaning off to the left side, pretty bad coronal shift, okay? And her main complaint was, I had this pain right freaking here, right? Now, of course, most spine people are like, she needs to get deep pelvis. Okay, she's 84. I don't think she wants that. She has no neurologic symptoms whatsoever, just pain right in that area. She's got a leg length discrepancy at the same time. So hers is definitely a compensational mechanism in some way, shape, or form. I went up to her because I was not going to put her on the table. I took my hands on both her iliac crests and I said, I'm going to put a little bit of support here. You tell me how you feel. Pressed it in. She could finally stand straight. Second I let it go, she back off to the lane. She's holding on to her walker, feeling that steady. Again, maybe that's something that's psychological. He said, weightlifting buddy, that's how you would spot me. You kind of press on my hips and pull out, stand up. But no, in a case like that, again, that just shows that that can be powerful. That sometimes on that compression test, give it a second. You take your hands off on the pressure, all of a sudden it's like, ooh, now I'm starting to feel it. Once you let the pressure off, the support goes away. Now the person has to stabilize and they feel it. They go and they stand up, even worse. So compression isn't completely confined to when I press down, it hurts. Sometimes it depends on when I get them to change positions after I take that pressure off. That's when the pain comes on. Anyway, radial frequency ablation, no one knows anymore. Insurance won't cover it. It was beneficial for a time. If somebody has diffuse arthritis of their spine, facet arthropathy, you do what's called a medial branch block, where you can ablate the nerve that essentially tells the brain I had back, right? Unfortunately, again, it used to be a procedure that was covered quite a bit for the sacroiliac joint, not anymore. Therapeutic SI injection, yes, and then we swing over to the minimally invasive SI joint fusion. In the first column, you see the allograft, right? So literally, you can put a plug of cadaver bone graft into the joint, and that is probably the most appropriate thing for that little osteoporotic lady, right? Now she's being treated, bone's getting stronger, the DEXA comes back normal, maybe she could have something else. Phasing into the real deal implants, the titanium implants, first generation is going to be that top one where it kind of looks like a triangle spaceship, something out of Star Trek. And then you have more kind of a traditional ortho screw below that, which is more the traditional way that it's done now. And either way, it's porous titanium, so it allows to have a better interdigitation of the bone, and also that screw actually extracts marrow from the ilium as it spans across the SI joint, so it makes it more powerful in that case. There's pain specialists that are doing this procedure now. So another reason I think that it's important for PAs to turn their hats, if you are friends with somebody in ortho or spine, ortho trauma, I think even general surgeons start doing this, okay? Do it. You're gonna be in better hands because you're surgically trained. I don't want to take anything away from the pain specialist. I have some very good pain specialists I'm very fond of. But there's just something about thinking about them putting in screws without doing a surgical training. Just going to a course needle do is kind of like, stick the allograft, I'll stick the titanium, okay? Let's just focus on that bottom part there. We know that PT is beneficial for everybody. General surgery, cardiothoracic, orthopedics, doesn't matter. PT treatment success is highly dependent on patient compliance. That's a great point, okay? Neuromuscular education, talked about in the beginning about a lot of this is, there's some muscular compensation issues that are absolutely going on with this patient. So even if you get to the root of the problem, thinking about the chicken before the egg kind of experiment, this person is still going to need PT for a long time. And the other thing is, honestly, they probably need about 3 months of physical therapy at the minimum before insurance will approve them for certain types of procedures. Serum injections, you can do them long term. Okay, yes, you're right. If somebody's getting a serum injection every 3 months, that's a problem to me. If somebody's like, I get an injection once a year, I'm not healthy enough to have surgery, even a minimally invasive one, that is a very good option for that person. Okay. Documentation, you know, it's important, 80% relief. Here's the old school way of doing the SI joint fusion. Let's just supplate the entire gluteus medius and take it from there. Smith-Peterson, does that name ring a bell? Surgical instrument familiarity? Yeah. Okay, anyway, well, maybe that's more fine. Smith-Peterson osteotomy is a thing that we do commonly in spinal deformity. There you go, hands raised, awesome. Gainsland, sound familiar? Told you about that before. And then just look at that core taken out of the ilium, that blue 1937. Now we're down to about the size of a nickel. That's a little bit generous. I think it's a little bigger than that, but it's still pretty small. Basic patient setup is going to be in a prone position, bumping the hips. We'll do flat Jackson or Jackson with hip rolls, and obviously trying to relax the legs. So very, very similar to a lot of spine positioning, or if this was ortho trauma. Think about if you were doing a closed reduction percutaneous pinning, so a femoral neck fracture that's not completely displaced, or it's not in that subcapital zone where they need a half hip replacement. And you're just putting in 3 cannulated screws, very, very simple. The whole idea of the intra-view here is basically harping on the point to say, again, the anterior posterior dimensions and seeing that we've kind of got this angle where the slope is coming back here. That's part of your inlet view. That's really important to see. I'm going to skip ahead to another slide here, go past this one, let you see what the final product is. These are the 3, whoa, too far. See, we're almost done. You guys are excited about that, okay? So stopping on this slide here, and I'm going to go back one just to kind of show you what the implant looks like with the sheet bone on it. This is kind of cool. The first picture of the lateral, I'm making sure that I have a very good picture of my sacral promontory right here, and my alar lines are nice and straight, okay? A lot of times that the patient might have their hips even rotated just a little bit, right? That can easily push one of those screws posterior to anterior. So making sure that I can really see crisp alar lines on the back and that sacral promontory. Inlet views for obvious reasons. As I said before, I don't want one of those screws poking too anterior, going too posterior. And then the outlet view, also very critical once you've got to identify your sacral foramen to make sure you're not advanced too far from lateral to medial, okay? Typically, when we're doing these procedures, a lot of it, the lateral is kind of for the initial positioning, and then you're just going to the AP and you're flipping between inlet and outlet as those screws are going in. So lateral for initial placements, you can put in some K-wires, basically in all these little spots. There's amazing guides and techniques and things now. The surgery itself takes about 45 minutes. That's the cool thing about it. So again, maybe you're bored, surgeon wants to get a little busier. It's a great thing that can really be life-changing for some people. So, oh, I said I was gonna go back and then we'll do questions. So self-tapping, self-drilling, what that means is typically when we're putting in screws in orthopedics, we are always putting in some type of a tapping instrument, meaning that we want to get a tunnel for the screws to have a little bit of an easier way to bite into the bone. Otherwise, you're forcing and making a hole, and then you're also kind of having a risk for fracture and those kinds of things in a patient that's more frail. The other thing I think I forgot to mention is that there actually is a good indication for this exact type of screw in treatment of sacral insufficiency fractures, right? So instead of doing a bone paste or bone cement to fix that instead, this is actually a pretty fantastic way to stabilize that. So anyway, moving on. Questions? You in the back.
What kind of screw do you recommend?
It should be something that is titanium, ideally. There are many companies that make them. And of course, I could tell you one that is favored. But for the purpose of your education, I think it's important that you guys observe and see that multiple companies are also producing a lot of these types of surgical implants. But that being said, personal preference would be, I think it would be something that is a titanium, and that is going to have some kind of porous coating, and it's also typically a lot of the things now with the surgical implants is they are all coated with hydroxyapatite. You guys know about this, right? Check your toothpaste, right? It's in the toothpaste now to restore enamel. And the crazy thing is, again, it's actually been a few years now that we've been starting to incorporate this into a lot of the surgical hardware. And what that does, again, it helps with better bone growth onto the implant. Yes?
Yeah, the minute you said hydroxyapatite, did I hear you say that correctly?
Yes.
Okay, because that just rings a bell in my mind, because that's exactly what we use for orbital implants to place in the orbital socket, believe it or not, following post-enucleation. So as soon as the globe is removed, we fill the volume with the hydroxyapatite implant. So that's pretty neat to see that
Amazing.
fill out.
I use toothpaste, I love it. Right. Any questions? You guys are convinced. Appreciate your time. It's my little pupper that had surgery. She's about 2 months post-op from a canine cruciate ligament tear. So they don't, the recommended treatment for that is not actually to repair the ligament, because good luck keeping a dog not wavering. So instead they do a tibial plateau lateral osteotomy. So, but she's walking feisty as ever. So thanks guys, appreciate it.